الاستاذ دكتور بنعمل الازازيل هيتكلم على الميمبرنس والميمبرنفرايتس ان شاء الله باذن الله تعالى تكون عشان انا اسفه معلش سلام عليكم.
المحاضرة الثالثة في السيشن بتاعتنا النهارده هتبقى عن الميمبرنفرايتس. هنتكلم في الميمبرنفرايتس عن الديفينيشن الباثوفيسيولوجي والفيسيولوجي اوف الميمبرنفرايتس، والمين بوينت في المحاضرة بتاعتنا في البرزنتيشن بتاعتنا هتبقى عن how to manage, which drug to use, when to start the immunosuppressive medication in patient with membranous nephropathy. Let's start by definition of membranous nephropathy. Membranous nephropathy is a glomerular disease in which immune deposition of IgG and complement usually deposit in the subepithelial surface of the glomerular capillary wall. Deposit formation is usually associated with marked increase in the glomerular permeability to protein, which is manifested clinically as nephrotic syndrome. That definition of membranous nephropathy. What about the epidemiology? 16.4 cases per million adult. Onset most commonly in the fourth and fifth decades of life. 75% idiopathic. Focal segmental glomerulosclerosis has overtaken membranous nephropathy as the most common cause of nephrotic syndrome in adults. يعني كان من فترة بيقولوا إن membranous nephropathy is most common cause of nephrotic syndrome in adults. These days, FSGS is more common than membranous nephropathy. What about male to female instance? About 2 to 1 male to female instance of membranous nephropathy. What about pathophysiology of membranous nephropathy? Usually start by circulating IgG antibody directed against endogenous antigen on or near podocyte food process, leading to formation of immune complex and activation of the complement component, especially C5P9, which is called membrane attack complex, leading to disruption of the membrane and protoglobin. What is the precipitating engine for this complement activation? Actually, it is not known, maybe due to some autoimmune disorders like double-stranded DNA, maybe due to some infection like hepatitis A and hepatitis C, and in most of cases it is not well known, it is unknown. So, the process is usually start by complement coactivation. It may be due to in situ deposition of immune complex in the glomerular basement membrane, either from the circulation or inside formation or extrinsic antigen bind to antibody and deposit in the glomerular basement membrane. What is the sequence of this deposition of the immune complex and the pathophysiology of membranous nephropathy? As we said, antigen-antibody deposition leading to complement activation, especially membrane attack complex, and to disruption of the glomerular basement membrane and development of proteinuria and nephrotic syndrome. This is the evidence usually occurs in membranous nephropathy. What about idiopathic membranous nephropathy and secondary membranous nephropathy? Idiopathic membranous nephropathy is the leading cause of nephrotic syndrome in white adult. This is the first point. And incidence remain constant over 3 decades if in comparison to IgA nephropathy and FSGS. Secondary membranous nephropathy account for about 1/3 of cases. And this is not the rule in the incidence of membranous nephropathy. We will see in one of our slides later on the incidence is completely different in America if we compare it in China. Secondary membranous nephropathy account for about 1/3 of cases. Both idiopathic and secondary membranous nephropathy have similar clinical manifestation. So the rule in this situation is to exclude secondary causes of membranous nephropathy before saying that this patient got idiopathic membranous nephropathy. What about the etiology for membranous nephropathy? Maybe due to immune disorders, secondary membranous nephropathy, maybe due to immune disease, maybe due to infection, malignancy, drug and toxin, and miscellaneous causes. Actually, the list is quite big. In autoimmune disorders, it may be due to systemic lupus, rheumatoid, mixed connective tissue, infection. We got a big association with hepatitis C, hepatitis B, and sometimes HIV. Schistosomiasis also may be encountered in some cases of membranous nephropathy, hydatid disease also. What about malignancy? Maybe due to carcinoma and non-carcinoma. Carcinoma, the strong association with lung, esophageal colon, and non-Hodgkin lymphoma and leukemia and non-carcinoma. Drug and toxin. there is a big list of drugs may be responsible for secondary membranous nephropathy in the form of gold, penicillamine, captopril, and Mycelium causes delusion. There may be strong association in diabetes, and in some diabetic patients we sometimes found proteinuria exceeding 10 grams per day, maybe due to membranous nephropathy. Sarcoidosis, sickle cell anemia, maybe also with Guillain-Barré syndrome and myelodysplasia. This is the etiology. What about the reported incidence of secondary membranous nephropathy? This is a multi-analysis study for different studies from China, Japan, France, and United States. Idiopathic membranous nephropathy represent about 31% of cases in China, while it represents about 62% of cases in the United States of America. Secondary membranous nephropathy in China about 68%, in the United States of America about 37%. So I think the difference between idiopathic membranous and secondary completely different from one country to the other, as we see in this meta-analysis. What about the clinical manifestation of membranous nephropathy? I think the clinical manifestation of membranous nephropathy is more or less the same clinical manifestation of any nephrotic syndrome. Usually affect on age, as we said before, fourth and fifth decade, rare in children, big incidence fourth and fifth decade, nephrotic syndrome 60 to 70% of patients at the time of presentation. About 60% of patients who present with subnephrotic range proteinuria will progress to full nephrotic syndrome within 1 or 2 years from presentation. Microscopic hematuria in 30 to 40% of cases. What about clinical manifestation? 80% present with nephrotic syndrome, hypoalbuminemia, hyperlipidemia. 70% of our patients have normal blood pressure and normal glomerular filtration rate. What about natural history of membranous nephropathy? Membranous nephropathy is a chronic disease with spontaneous remission and relapse. We usually got the rule of third in membranous nephropathy, spontaneous remission within the first 2 years after presentation in 1/3 of cases, low rate of spontaneous remission of the patient present with higher degree of proteinuria, more than 8 grams per 24 hours. What about also the difference between membranous nephropathy and other causes of nephrotic syndrome? We usually got some complication which may lead to rapid deterioration of the kidney function, like renal vein thrombosis, crescento glomerulonephritis, and antiglomerular basement membrane disease. And also there is increased risk of thromboembolic and cardiovascular events in patients with membranous nephropathy due to very high level of protein excretion in urine or 24-hour urine protein collection. What about the diagnosis and workup? It is more or less the same in all cases of nephrotic syndrome, but we usually stress on renal biopsy is mandatory if we compare it to minimal change. We usually look for other etiology or secondary cause for membranous nephropathy. So we usually ask for hepatitis B, hepatitis C, immunology screening, and asking for complement C3 and 4. What about in selected patients? If we suspect thromboembolic events presenting with flank pain, hematuria, or acute renal injury, we should ask for renal vein Doppler ultrasound or MRI. With sudden deterioration in the kidney function, we should think about other etiology like antiglomerular basement membrane antibody or ANCA-associated vasculitis. If there is suggestive symptoms of our patient to more than 50 years of age, we usually ask for cancer screening. And I think we usually order some sample investigation to exclude underlying malignancy. If we suspect sample chest X-ray is enough. If we suspect abdominal malignancy, abdominal ultrasound or CT is enough. And in old male, we may ask for BSA to exclude secondary causes of membranous nephropathy. So sample investigation to exclude secondary causes of membranous nephropathy. What about histopathology? اعتقد ان الدكتوره منى طبعا عملت لنا good explanation for histopathology. بس هوريكم sample slides. This is the normal glomerulus. What normal glomerulus by light microscopy? What usually occurs in membranous nephropathy? There is thickening of the glomerular basement membrane and mesangial expansion. Immunofluorescence. There is diffuse granular IgG deposition along glomerular basement membrane, and silver staining usually show spike pattern in the glomerular basement membrane. What about electron microscopy, we'll see normal electron microscopy, thin glomerular basement membrane, thin nice glomerular basement membrane with effacement of the epithelial fold process. What happened in membranous nephropathy? There is usually thickening of the glomerular basement membrane with some epithelial deposits, and there is effacement of the fold process. This is the electron microscopy of membranous nephropathy. What about the prognosis of membranous nephropathy? Good prognosis usually in female, young age, normal creatinine level less than 4 grams proteinuria per day for 6 months, and there is no tubular interstitial disease. Poor prognosis usually associated with higher level of proteinuria, especially more than 8 grams protein per day for 24 hours, for 6 months. What about rule of third? Usually complete remission about 1/3 of patients at 5 years. Partial remission, which is defined by less than 2 grams, but about 30% at 5 years. End stage, 14% at 5 years, 35% 10 years, 41% at 15 years. What about prognostic factors? We usually put the category of membranous nephropathy patient into one of these categories because it will depend, later on will depend on this classification on the selection of our management or line of management. Either low risk for progression, defined by normal creatinine clearance, proteinuria less than 4 grams per 24 hours, and stable renal function during an observational period, which usually extends for 6 months. Medium risk, defined by 55% probability for developing chronic renal insufficiency, normal creatinine clearance, proteinuria more than 4 grams per 24 hours, but less than 8 grams, and stable renal function during an observational period. And finally, high risk group, 66 to 80% probability of progression to chronic renal failure, and persistent proteinuria more than 8 grams per 24 hours, independent of the degree of renal function. So this prognostic value and the classification of the risk, medium risk, high risk, usually will depend on how to manage our patient. Prognostic value in a nice study by Catran et al. In Kidney International, year 2004, done on 350 patients with membranous nephropathy. 10-year survival was about 100% in complete remission, 90% in partial remission, and 45% no remission. And loss of GFR about 1.5 per minute per year in complete remission, 2 in partial remission, and 10 in no remission. So the higher of protein excretion in urine, the more the deterioration in the kidney function. What about treatment of membranous nephropathy? Either 2 lines of treatment, conservative treatment, or immunosuppressive treatment. We'll go in details through the different medication used in management of membranous nephropathy, and we'll finish our presentation by the KDOQI guideline published in year 2012 on the management of membranous nephropathy. Start by conservative treatment, restriction of protein diet, blood pressure control. التارجت بتاعنا في حالات الممبرنس nephropathy 125/75, control dyslipidemia with statin, which is mandatory, and ACE or ARBs. Immunosuppressive treatment. You should ask yourself these questions before starting immunosuppressive treatment. What should be the duration of conservative treatment? When to initiate immunosuppressive therapy? This is the second question. What is the most effective and safest available agent? And finally, how long should the treatment be given for our patient before failure is assessed or futility is assessed? Starting by the definition of complete and partial remission before going the medication. Complete remission in membranous nephropathy is usually defined by urinary protein excretion less than 0.3 gram per deciliter, confirmed by 2 value at least 1 week apart, accompanied by normal serum albumin concentration and normal serum creatinine. This is defined as complete remission. What about partial remission? Urinary protein excretion less than 3.5 gram per deciliter and 50% or greater reduction from the peak value, confirmed by 2 value at least 1 week apart, accompanied by improvement or normalization of serum albumin concentration and stable serum creatinine. This is the definition of complete remission and partial remission. What about the use of immunosuppressive medication? and membranous nephropathy. First of all, not used in low risk group as side effects are likely to exceed the benefit. This is the first point. Medium risk group first. Steroid therapy, monotherapy, there is no benefit in using steroid alone and membranous nephropathy if we compare it to minimal chances زي ما الدكتور ايمان قالت لنا في المحاضره اللي قبل كده. Steroid alone is not effective in membranous nephropathy. So we usually start with a combination of cytotoxic agent. طيب اول كومباينيشن ابتديناه في السايتوتوكسيك ايجنت او اول كومباينيشن حصل له بابليكيشن كان ده باي بونتشيلي ايتال في النيو انجلاند جورنال اوف ميديسين in 1989. 6 months of steroids in alternative with chlorambucil superior to conservative treatment in achieving complete remission. 50% versus 7% ده في الاستيرويد لو عملنا لهم كومباريزون مع الكونزرفتيف تريتمنت. وال 10 year follow up show that 8% of treated patient versus 40% of untreated patient reach end stage renal disease. ده اول حاجه اتنشرت باي بونتشيلي انتاج في النيو انجلاند جورنال اوف ميديسين. الابلكيشن الثانيه كانت عملنا ريبليسمنت للكلورامبيوسيل with oral cyclophosphamide وتقريبا كانوا more or less the same result. In recent trial by Jia et al. في جيسون 2007 looked at 47 patients on 6 months course of alternating prednisolone and cyclophosphamide versus 49 patients with supporting treatment. Treatment group 34% من 49 عيان 15 complete remission and 19 partial remission versus 16 في الconservative treatment. طيب what about السايكليك كورتيكوستيرويد والالكاينيتنج ايجنت اللي هو البونشيلي ريجيم؟ عشان نخلي الامور بالنسبه لنا سهله احنا بنقسمهم الى شهر 1 3 5 2 4 6 تمام؟ يعني الشهر الاولاني الشهر الثالث الشهر الخامس بندي فيهم ميثايل بريدنيزولون 1 جرام ديلي فور 3 دوزز وبعدين بعد كده بنكمل اورال بريدنيزولون الجرعه بتاعتنا 0.5 مللي جرام بير جي بير داي تمام؟ ده الشهر الاول. الشهر الثاني مانث 2 اورال كلورامبيوسيل اور سايكلوفوسفامايد وهنعرف ان دلوقتي البريفير دراج اللي هو السايكلوفوسفامايد ده بنستخدمه 2 مللي جرام بير جي بير داي فور 30 داي وزي ما اتفقنا مانث 1 3 5 ذا سيم ستيرويد اونلي ومانث 2 4 6 بيبقى cyclophosphamide. What or how to do follow up for your patient? Which monitoring will you do for your patient during this regime? Monitor every 2 weeks for 2 months شهرين اولانيين وبعدين بعد كده every month for 6 months. ايه المونيتورنج او ايه الحاجات اللي احنا بنعمل بيها مونيتورنج للعيانين بتوعنا؟ سيرم كريات، يورينال بروتين اكسكريشن، سيرم البومين اند وايت بلاد سيل كاونت. لو حصل عندي ريدكشن للتوتال ليكوسيتيك كاونت to less than 3050 then hold chlorambucil and cyclophosphamide until the patient recover and the number increased to more than 4,000. What about the contraindication for the using of cyclic corticosteroid alkylating agent? Untreated infection like HIV, hepatitis B, neoplasia, retention, inability to comply with monitoring, pre-existing leukopenia, and if the serum create more than 3.5 milligram per deciliter. What about the alternative treatment? If we use this kind of medication, steroids plus cyclophosphamide, or steroid plus chlorambucil, what is the other line of treatment if we get failure with this regime? We may use cyclosporine. Single randomized control trial of 51 patients with membranous nephropathy. Low dose prednisolone plus cyclosporine versus prednisolone and placebo. 78% in cyclosporine group versus 22 achieved partial or complete remission. Relapse rate of 40% within 1 year of discontinuation of therapy, but we shouldn't consider this failure of therapy because the relapse rate in treatment with cyclosporine is very high either in membranous or minimal change. Majority of complete remission occurs after 6 months of treatment. So, after 3 to 4 months of cyclosporine glutamate is not significantly reduced, it is unlikely that cyclosporine will be effective. يعني أنا لو استخدمت السايكلوسبورين مع العيان بتاعي for 4 months وكان الريسبونس بتاعتي مش كويسة هقول إن تقريبا السايكلوسبورين will not give a good result later on. Prolonged low-dose cyclosporine has been suggested for long-term maintenance with little risk for nephrotoxicity. What about tacrolimus? In a study by Prof. et al. at Kidney International 2007, administered tacrolimus monotherapy to 25 patients with normal renal function, and Ameer proteinuria of 8 grams per 24 hours for 12 months, with a 6 months taper versus 23 control. 18 months, the probability of remission was 94, tacrolimus group comparing to 35% in control. Second endpoint was 50% increase in serum creatinine, was reached in 6 control patients and 1 tacrolimus group patient. Relapse rate of about 50% after withdrawal. So this is the regime for calcium urine inhibitor, either cyclosporin, tacrolimus. What is the starting dose for cyclosporin, which is the difficult point? Which dose to start with? Usually you start by 3.5 to 5 milligram per kg orally in 2 equally divided doses, 12 hours apart, with prednisolone 0.15 milligram per kg for 6 months. We usually start with a small dose and build up the dose according to the response of your patient, with tacrolimus 0.05 to 0.075 milligram per kg and equally divided to doses, and for 6 to 12 months like cyclosporin. What about the patient with very high risk for progression? As we said before, steroid not beneficial, combined with cytotoxic agent. Cyclosporin, 1 randomized control trial showed benefit in 17 patients after 12 months of treatment, with sustained result in 50% for 2 years after discontinuation. MMF, possible benefit from 3 grams per day dosing. This is for high risk for progression. What about rituximab? It is expensive drugs, but we usually meet a lot of patients with membranous nephropathy not responding on either steroid with cyclophosphamide or steroid plus cyclosporin. There is some trials on rituximab. Experimental data suggests that B-cell activation leads to IgG4 deposition along the glomerular basement membrane, which leads to injury to the membrane and proteinuria. This is the mechanism of action targeting beta cell and delay the progression of this autoantibody. So this is the mechanism of action of rituximab. In a systemic review by Bombik et al. And C. Jason, 21 studies were included, 12 were single case report, and 9 were case series ranging from 2 to 50 patients. Both primary and secondary membranous nephropathy were included in this meta-analysis, and principally used as the second line therapy except for one study. Diamond rituximab used as the second line therapy, not first line therapy. What about the result? Response rate was as follows: complete remission 15 to 20%, partial remission 34 to 40%, similar to response rate for alkylated agent. And the result of rituximab more or less the result of cyclophosphamide or chlorambucil، مع الفرق الضخم جدا في السعر ما بين الريتوكسيماب والسايكلوفوسفاميد او السايكلوسبور. We need a well-designed randomized control trial comparing rituximab to standard therapy such as Okeli regime. الويك بوينت في اليوز بتاع الريتوكسيماب او الاسئله اللي المفروض نسالها: should rituximab used at the first line of therapy? There is no data. What about the dose of rituximab? There is no consensus about the dose of rituximab in membranous nephropathy. What about the long-term risk and benefit? No long-term data for rituximab in membranous nephropathy is available so far. What about immunotherapy? There is some study about esnt with good response, but so far there is no use for esnt in the management of membranous nephropathy. What about KDIGO guideline, which was published in 2012, about selection of patients with idiopathic membranous nephropathy to be considered for treatment? If this patient got urinary protein excretion persistently more than 4 grams, this is the first thing. There is also the presence of severe disabling or life-threatening symptoms related to nephrotic syndrome is indication for immunosuppressive therapy. Or there is rising in serum creatinine or by more than 30% or more within 6 to 12 months from the time of diagnosis. We usually don't use immune suppressive therapy in patients with serum creatinine persistently more than 3.5 milligram, or there is a reduction in the kidney size on abdominal ultrasound, or those who have concomitant severe or potentially life-threatening complications. These are contraindications to the use of immunosuppressive therapy in patients with membranous nephropathy. Initial therapy of membranous nephropathy or idiopathic membranous nephropathy, usually alternating dose of corticosteroid and oral alkylating agent. Which is preferred? We suggest using cyclophosphamide rather than chlorambucil. We recommend patient to be managed conservatively for at least 6 months. If no response, start by steroid with cyclophosphamide or chlorambucil. When to do another kidney biopsy? Perform a repeat kidney biopsy only if the patient have rapid deterioration of the kidney function. Doubling of the serum create over 1 to 2 months of observation in the absence of massive proteinuria. And we usually adjust the dose of cyclophosphamide according to the age of the patient and estimated GFR. What about if there is no response for alkylating agent like cyclosporine? We usually shift our patient to calcium urine inhibitors. We suggest that dose of calcium urine be reduced at interval of 4 to 8 weeks with when we get response to treatment. Treatment of idiopathic membranous nephropathy resistant to recommended initial treatment. Patient with idiopathic membranous nephropathy resistant to alkylating agent, you should shift your patient to calcium urine inhibitors, and if there is no response to calcium urine inhibitor, you should shift your patient to cyclosporine. Treatment of relapse of nephrotic syndrome in adult with idiopathic membranous nephropathy. If you start by steroids and cyclophosphamide, shift your patient to calcium urine, and the reverse is right. And finally, this is the final slide. This is the algorithm for management of membranous nephropathy. Moderate proteinuria and heavy proteinuria. Moderate proteinuria start with conservative treatment. If there is a response, continue with conservative treatment. No response or persistent proteinuria more than 4 grams per day, shift your patient to cytotoxic plus steroids or calcium urine inhibitors. If there is no response, shift your patient to the last tries will be pyridoximab or the CTH. Thank you. سنجل دوز. معظم الكومبينيشن سنجل زي ما بنسميها في الادلت بقى سنجل دوز. مورنينج عشان السكيتة الناس بتاعتها. بتدي نعم أي أسئلة تانية؟ طيب دكتور محمد